Endoscopy is both a diagnostic and therapeutic modality for esophageal foreign bodies. For one, endoscopy confirms the presence of the foreign body within the esophagus, what exactly it is, and the real-time visualization of the degree of damage to the esophageal mucosa. Also, depending on the foreign body, it can be dislodged from the esophagus and removed through endoscopy as well. Let's begin. What is an endoscope? Endoscope is a tube with a viewing port and or a video camera attachment that is inserted into the stomach through the mouth or the colon via the rectum. The endoscope permits inspection of the inside of these hollow organs. There are flexible endoscopes, as seen in the image right here, which we use for the visualization of the esophagus, stomach, and the colon. There are also rigid endoscopes, wherein the insertion tube is straight and non-flexible. Examples of rigid endoscopes are the ones used during rhinoscopy, arthroscopy, and laparoscopy. This equipment provides real-time visualization of the mucosa of hollow organs and to provide therapeutic options with less surgical trauma. Endoscopic retrieval forceps can be inserted into the biopsy channel of an endoscope for you to be able to grasp a foreign body once it is seen through the endoscope. It is also used to biopsy organs without any incision through the ventral midline to reach these organs. These forceps could have different appearance of the tips. This could be a long-jawed forceps or even a net for those foreign bodies which are very slippery or quite big that you need to entrap them within this web or this net for them to be pulled out of the esophagus or the stomach. The opening and closing of these forceps is controlled by a handheld control. So how does this work? The electrical contact, this part here, connects to the TV monitor and the endoscopy machine. The controls are held by the veterinarian. How the controls are used dictate how the other end of the endoscope moves within the body cavity of the animal. Yes, that is a stuffed animal. So the controls can move the tip up, down, left, and right. It can even rotate it. And on its end, right here, is an objective lens and light guide, which registers the images onto the monitor. A biopsy channel here, which cannot be seen as much, right here. A biopsy channel is a hole wherein you can place the endoscopic retrieval forceps into. So you can use these to retrieve or remove foreign bodies, or you do biopsies. You can also flush air and water through the endoscope to the organ through the holes in here. And at the same time, it also has suctioning functions. For example, there is a lot of fluid in the stomach, which will limit your capability to grasp a foreign body. You can suction that out rather. So yeah, basically that's how it works. Now let's apply it to the esophageal foreign bodies. Our goal for patients with esophageal foreign bodies is to remove it with an atraumatic meticulous technique. Doc, why atraumatic? This is surgery, right? Well, the esophagus has a poor healing capability. Number one, it has no serosa. Remember, the first layer is an adventitia. If there is no serosa, early fibrin sealing which usually occurs during the earlier part of wound healing, it occurs more slowly than the other gastrointestinal sites. Second, there is no omentum which we can wrap around the esophagus to help it heal faster. Also, remember that the esophagus has a segmental blood supply. So if the blood vessel supplying that region is damaged, healing is compromised already. The esophagus is also in constant motion, so any trapped foreign body would cause distension. And the esophageal tissue is intolerant to stretching and will eventually be torn. All of these can be addressed by endoscopy. Endoscopy is used to visualize the esophageal lumen in real time. This remains as the treatment of choice for movable esophageal foreign bodies. Emphasis on movable. For those foreign bodies which are movable in the cervical and proximal thoracic esophagus, it can be grasped with those endoscopic retrieval forceps, pulled out of the esophagus, and retrieved from the mouth. For those in the distal thoracic and abdominal esophagus, depending on if it has sharp edges, it can be retrieved from the mouth or pushed to the stomach. Whoa, wait doc, it's a foreign body. We want to remove it. Then why are we pushing it into the stomach? We should retrieve it through the mouth. Why not pull it? Why? Why indeed? Stay tuned to find out. We will discuss it more in the other lecture videos, so just wait. For the preoperative concerns, a radiograph must be taken and examined carefully before choosing your treatment approach. You should have an idea already as to where the foreign body is lodged. A radiograph of the thoracic cavity can also give you an idea of any respiratory manifestation of the obstruction. If there is, the patient needs to be stabilized prior to anesthesia, and you must be able to craft an individualized anesthetic protocol for such a patient with anesthetic risk. Patients must be intubated to secure the airway during the procedure, prevent iatrogenic aspiration pneumonia, and facilitate gas anesthetic administration. Antibiotic therapy is always indicated, more so for patients with suspected esophageal perforations and signs of pneumonia. So how is this done? Patients are positioned on lateral recumbency with their necks extended. The heads may be supported with cushions made from folded towels or cloths. Ideally, endoscopy is done on a sink table with workable countertops to facilitate a cleaner surgical environment and drainage of fluids. The endoscope must be prepared and calibrated already before the animal is anesthetized and intubated. If possible, use a large diameter endoscope to facilitate better visualization and more esophageal dilation. A lubricant is placed on the tip of the endoscope and is gently inserted into the oral cavity with a veterinarian guiding it into the esophagus. Assess the esophageal mucosa as you look for the foreign body. Once you see the foreign body, try to identify what it is and the possibility of damage to the esophagus if you try to move it. Water-soluble lubricants may be flushed or applied into the lumen to make retrieval easier. Do not forcefully manipulate an object that is firmly embedded into the esophageal wall. Gently nudge the foreign body to assess if it is movable. Depending on the foreign body and its mobility within the esophageal lumen, you may use the forceps to grasp the foreign body and bring it up or pull it up to the oral cavity. If you find that the foreign body is movable but will cause more esophageal damage if you try to pull it out, and it is distal enough, carefully push it down to the stomach to be removed via gastrotomy or to be allowed to dissolve. Foreign bodies like mango seeds, apple core, corn cobs, and metallic foreign bodies like fish hooks need to be removed. Large food boluses and very small blunt-ended bones can be left to dissolve. It is ultimately your choice what to do at this point. That choice needs to be justified with your clinical knowledge and assessment of the animal and the real-time situation. There is no book that will tell you what to do and what not to do, because it will all depend on what you see at that moment. To see how videos of how endoscopy is done, click on our next lecture video.